You're listening to the Addiction Medicine Podcast, the official podcast of the Governors Institute. If this is your first time listening, thanks for joining us. The Addiction Medicine Podcast is designed for healthcare professionals and others interested in addiction medicine and will feature thoughtful conversations and insights from clinicians, patients, and families, policymakers, and other stakeholders. Remember to make us a favorite wherever you get your podcasts. You can also stay connected with us at governorsinstitute.org or follow any of our social media channels at @govinst.
Welcome to the second season of the Addiction Medicine Podcast. I'm Dr. Sarah McEwen, Executive Director of the Governors Institute. If you're paying any attention at all, you know that substance use disorders provide huge challenges to individuals, families, and society in general. The SUD landscape is quickly and dramatically changing, increasing the already urgent need for accessible prevention, treatment, and recovery support services for all patients who need them. Over the past 13 years, the Governors Institute's Addiction Medicine Conference in Asheville, North Carolina, has become the region's premier conference for substance use disorder-related education. The 2022 conference was no exception and provided an opportunity for in-person training, skill building, and networking. In this first episode of Season 2, you'll hear an outstanding presentation from this past spring's conference by Dr. Matthew Johnson, a professor of psychiatry and behavioral sciences at Johns Hopkins University, who has published widely and conducted seminal research on the effects of psychedelics. This presentation, Psilocybin in the Treatment of Mental Health, explores the research on what is known about hallucinogens' treatment effect on smoking cessation, depression, and anxiety, as well as the potential use for alcohol use disorders and a variety of behaviors besides addiction. Dr. Johnson also addresses possible mechanisms for how behavior change is achieved with these agents. The slides that coincide with this presentation can be found on our website, addiction-medicine.org. We hope you'll find it informative and engaging.
Well, thanks for the invitation to speak. This is going to be about something a little bit different, but it's been a topic I've been working on for 18 years, and hopefully it'll start some discussion here. So before going any further, just by way of disclosure, I do serve as an advisor to several companies that are moving psychedelics or related compounds through the FDA or international equivalent medical pathways to be approved as medications. However, what I'm presenting today has nothing to do with the work of these particular companies or with their particular products. What I'm going to be telling you about is largely concerning the compound psilocybin. So this is the active agent in over 200 species that have been identified of so-called magic mushrooms, mostly in the Psilocybe genus of mushrooms. Pharmacologically, psilocybin is what we call a classic psychedelic. Now, there's a lot of drugs that are often called psychedelic, drawing from a kind of a broader definition of their effects. So you have MDMA, which is known on the street as ecstasy, which is a serotonin releaser. You have ketamine and PCP, dextromethorphan. These are NMDA and antagonist glutamatergic acting compounds. These are the classic psychedelics activate the serotonin 2A receptor. So they act postsynaptically on one subtype of serotonin receptor, act as agonists of that receptor. And that puts psilocybin in the same category as LSD, mescaline, which is in peyote and some other cacti, dimethyltryptamine, or DMT, which is in ayahuasca, the South American sacramental concoction you may have heard about in religious use. So what I'm going to say about psilocybin, for the most part, drawing from these shared mechanisms, are going to be similar to, most likely, to these other compounds, certainly in terms of the risk and safety profile I'll show you. Psilocybin is interesting because the data suggests that there's not only a historical use, but prehistorical use. It's quite ancient. So on the left and on the center, I'm showing you photos of artifacts from Meso and South America suggestive of sacramental use dating back several hundred to a few thousand years ago. On the right, I'm showing you a photo of a cave painting from Algeria, Northern Africa, And although it is arguable, it's suggestive of sacramental use of these compounds. If you can't see, there's little folks dancing around. Their heads have been turned into giant mushrooms, and each hand is filled with mushrooms, and they're all kind of dancing around, almost like some Grateful Dead bears. So again, arguable, but this is 9,000 years ago. It's been dated too. So that's quite combined with evidence that the mushrooms would have grown in the area, in the environment at that time. And that's several thousand years before the first human civilizations popped up in Mesopotamia. So that's the ancient aspect. So fast forwarding some millennia, we get to the 1940s, and that's sort of the beginning of the first wave of modern classic psychedelic research, really prompted by the synthesis of LSD by Albert Hofmann, working for a pharmaceutical company in Switzerland during World War II in the late 30s, but then his discovery of the psychoactive effects of LSD in the early 40s. And there were some mechanistic and sort of investigations using these compounds to try to understand things like the nature of schizophrenia. It was thought that they might be modeling an endogenous compound, perhaps, that is causing schizophrenia. So that led to some hypotheses and investigations and some similar investigational lines. But in terms of therapeutics, folks, there were two, I would say, most promising areas of investigation using primarily LSD in the treatment of one, cancer-related distress. So these were terminal cancer patients, and then two, treatment of alcoholism. And then there were the Dark Ages. I don't know if you can see my background, but there's like a guy hanging from the town square in a medieval setting. So despite some promising preliminary findings, really from the era of the 1950s through the late 60s, early 70s, there was this decades-long dormancy that really lasted throughout the 90s, and things didn't really get started again in human research until the early 2000s. And this was a reaction, one, to very real casualties when LSD, it was really unthinkable to some of these researchers in the early 60s that these would be widespread drugs of abuse. But we get into the mid 60s and then really into the late 60s and early 70s. LSD became quite popular as a recreational drug. And if you have a chance to talk to psychiatrists and folks who were in the ERs in those days, there's some harrowing stories. The average doses of LSD in those days was 6 times higher than the average dose of LSD on the street these days. So 300 versus micrograms versus 50, quite a difference. There were some bad trips. But there was, this was when youth were using it, this was the blind leading the blind. Certainly a number of people would have had vulnerability. Talk to you more about that. People using in situations with no risk mitigation strategies. But then there was really, I would say the biggest thing was not just the casualties, but the sensationalism by the media. The media went from, uber enthusiastic to just, you couldn't get a positive story on this stuff, medical use of psychedelics published in the early 70s. And that was really this, I'd say, a failure to distinguish between the risk-benefit profile that we see in cautious application of research, addressing the known risks versus, as I said, the riskiest of use, the blind young people leading young people with no awareness of the risks. So if those were the dark ages, you might say we're in an age of enlightenment in terms of really investigating these things scientifically once again, or it's been called a psychedelic research renaissance. So I'm plotting you the scientific papers with psychedelic or hallucinogen, which is a synonym, in the title of the paper. Going back to 1980, you can see there are 5, 10, 20 papers a year kind of bouncing up and down with a pretty low baseline. And then again, you get into the early 2000s and you see this like exponential uptick in interest in these compounds. And that was around the time I was lucky to get into this field. And although some of that work is certainly mechanistic and non-human, I would say it's the vast majority is really inspired by some of these really astonishing clinical findings, some of which I'll show you here today. I don't give a talk about this stuff without really emphasizing that there are risks. I don't have the time to go into detail, but I would point people into two key publications I've put out there over the years. I've tried to make this a real focus of my career in dealing with these, like keeping the dark side in mind. So these publications from 2008 and then more recently 2018, reviewing what we know about the risks and then what we can do to address those risks. And then more specifically in that more recent paper, what the FDA should do if psilocybin does pass phase 3 trials for the treatment of a disorder. If FDA is to approve it, how should it be scheduled if it is moved outside of Schedule 1? And what rules should the FDA apply to keep things safe? I'll mention briefly the two kind of most relevant risks. They're not the only ones, but people have heard of the bad trip. That's a real thing. The really bad thing is dangerous behavior where someone gets harmed. It's relatively rare in terms of recreational use, but it does happen. People have fallen from heights, just like they do with alcohol and other intoxicating substances. It shouldn't be surprising. People have panic reactions. The bad trip is the most likely negative outcome. The anxiety, the fear, that's going to be temporary, but again, it's kind of the behavioral toxicity, like running into traffic, for example, or being in a dangerous situation where you can get hurt. And then there's for a small percentage of the population with an identifiable predisposition to psychotic disorders or bipolar. It's thought really through clinical observation over the decades that an experience with psychedelics can destabilize these individuals. And I view this in the same light as we know any number of life events can destabilize these people, especially with not a stable life background, without a steady family structure, et cetera. So, fortunately, we can screen for that. And I'll mention one more risk, and that's the risk of addiction that does not appear to be there for psilocybin or the other classic psychedelics. I want to be clear, these drugs are certainly abused, meaning used in a way that can be dangerous to the self or others, but they're not drugs of compulsive drug seeking or addiction. And really all of the evidence, there's no controversy. I mean, the National Institute on Drug Abuse has declared this for decades now. I mean, the epidemiology, especially when you make sure that drugs like PCP and MDMA aren't included with the classic psychedelics, the epidemiology supports it. We know from the way it works, it's been mentioned, the mesolimbic system, I should say the way these drugs don't work in the mesolimbic system, the dopamine response is not like what you see with other addictive drugs, even with cannabinoids. And reliable animal models of operant drug reward. So we know from every level of analysis. However, that certainly doesn't tell us that they're going to be effective for addiction, but I'll tell you more about why we think they might help in the treatment of addiction, but that's important to know. But going across all of these risks, just the important thing is through screening people, through preparation, through monitoring, we have 2 professionals in the room during these psilocybin sessions with them, and through follow-up care, we can address these known risks to an acceptable level. And I would say one that's very acceptable compared to much of what we do in the practice of medicine and clinical psychology. Okay, so I'll move into our the first of the therapeutic studies I'll show you using this compound. This was in cancer patients, not necessarily terminal, but they had to have life-threatening cancer. And these were 51 patients. There's no DSM disorder that describes existential anxiety from cancer. I think there may be one day because it looks, I think there's a literature to support it's being a distinct entity. But what we did here was we took DSM criteria spanning a number of predefined disorders that involve either depressive symptoms, anxiety symptoms, or a combination of both, and they had to be claimed by the participant due and instigated or exacerbated by the cancer diagnosis. And so about a third of folks fell in each of those categories, depressive symptoms, anxiety symptoms, or both. Study design briefly, it's a crossover study within subject. Everyone got the real deal high dose psilocybin, and everyone else in another session, everyone got 2 sessions. The other one was a trivial dose, a low dose, really meant to serve as an active placebo. And specifically, it was so low that we judged probably most people wouldn't feel it, but it was more to maintain instructional control. We can tell everyone honestly that you'll receive psilocybin in each session. The dose may range We did guarantee that at least one of the sessions would involve a moderately high to high dose that they would most likely feel, although that could be 2 sessions like that. It could be low and a high and medium high. We kept them on their toes. But in reality, the subset of those conditions that they actually received, which is they were blinded to, is everyone had 1 high and 1 low. And basically, we followed up with symptoms 5 weeks after each of these 2 sessions. And so the sessions were 5 weeks apart. And then we had a 6-month follow-up. And I'm stepping you here through the our primary depression and anxiety inventories. This is the Hamilton Depression and Anxiety Inventories, clinician-administered structured assessments. Both groups, before they were randomized, came in at very high levels at baseline on both depression and anxiety, as you can see from the blue and red groups. Again, not randomized. You would expect them not to differ. Post 1 is 5 weeks after that first psilocybin session. There's a dramatic reduction into the range of the scale on average. It's not indicative. It's the normal range of the scale, not indicative of a disorder. So they went from a clinically severe range to the normal range of the scale on average. Also a sizable reduction in the low dose group, likely due to the placebo effect, and also that preparation. There was 8 hours of preparation, including life discussion of the cancer, with the 2 guides, the professionals that would be in the psilocybin sessions with them. And then now 2 weeks after that, well, I should say that even that reduction in the low dose group, nonetheless, it's a reduction, but nowhere near as large as we saw in the high dose group. And now at post 2, that's 5 weeks after the second session. So now everyone's gotten the real deal dose, whether it was 5 weeks ago or 10 weeks ago. And so now both of those groups are down to that very low level of suffering into the normal range on average. And that looked, essentially identical, that pattern between both depression and anxiety. And these are big effect sizes. Right now, I'll move into something that sounds a little odd for pharmacology. It sounds a little woo-woo, frankly, but it's this construct of the mystical experience, which we've found time and time again to be a relevant construct when examining this this field. And so, again, it sounds woo-woo, but it is nominally divorced from any belief in any religious or supernatural belief, and it has deep roots going back to William James, the father of American psychology. James and other scholars were fascinated by the observation that if you look across the world's cultures, across history, different languages, there are extraordinary human experiences that are prompted by different things, like near death, acoustical techniques, fasting, prayer, sometimes drugs, sometimes just out of the blue. But James and others noted the remarkable similarities of some of these extraordinary human experiences, with the hypothesis that their descriptions that might reflect some cultural baggage that's sort of idiosyncratic, but that there's this core experience that human beings, not frequently necessarily within one's lifetime, but across the population, is very frequent, this thing called the mystical experience. And what that involves is one reporting an overwhelming sense of unity, expressed in different ways, depending on their beliefs perhaps, but feeling at one with the universe, one with all of humanity, one with God if they're religiously inclined, one with all of nature, a positive overriding mood, a sense of transcending time and space, almost as if those domains are no longer relevant. They've stepped outside those domains. And then a sense of ineffability, the idea that the experience is so far beyond words that it's indescribable. And so there are scales that have been developed to assess this. I'd say the most psychometrically validated scale is one that we developed, refined from a previous scale at Hopkins. But with that in mind, we used such a scale at the end of their psilocybin session, and I'm showing you, and we found that the degree of mystical experience, as measured once the drug wore off, but before they go home that day, the degree of mystical experience was predictive and correlated with the degree of reduction in depression and anxiety 5 weeks later. And that held up statistically after controlling for the individual's rating of drug intensity or drug strength. So what this suggests is it might be something about the experience, not just being hit over the head with a sledgehammer of a strong drug effect, but people have an experience that they learn from, and people will create a narrative and they will tell a story about their life of how they changed because they went through this experience. Very different than any other psychiatric medication that I can think of. I won't go through in detail, I'll move along, but our colleagues actually, we published together in the same journal. Our colleagues at New York University found with a complementary design, used niacin as the active placebo rather than a low dose, but also found large reductions in anxiety and depression of a large effect size. Moving outside of cancer-related depression and anxiety, the first formal study of major depressive disorder treatment with psilocybin was done by our colleagues at Imperial College London. This was the first study, a 12-person open label study, and they found reductions in depression here measured by a similar outcome of the QIDS assessment, but it persisted for at least 3 months. We've followed up that with the first randomized study. This was still an open label study, but it was a waitlist control. So people were randomized to either receive this treatment relatively immediately. They still had the preparation sessions, 8 hours of preparation, but then moved into those sessions. And the other group waited several weeks before they started that entire process. And you can see what I'm showing you here. This is another version of the Hamilton Depression Scale, but people moving from the severe range into dramatic, large reductions in depression into the normal range on average of the scale in the immediate group, and then no change in the delayed group. And what I'm not showing you here is that after there was a crossover after week 8, the delayed group then received 2 sessions of psilocybin, and there we saw reductions in depression at that point that were roughly equal in magnitude to the immediate group. So it seemed to hold up. And then our colleagues back at Imperial College, kind of bouncing back and forth across the Atlantic here, then they published the first double-blinded study using psilocybin for depression. And I would say these a little more complex, but I would say positive results. This study was a double dummy comparison. It was blinded. Everyone received either active psilocybin within these sort of psilocybin-like sessions, and then were sent home with a placebo for an SSRI. Or it was the opposite. They had the placebo for the psilocybin in the sessions, and then they were sent home with the real SSRI, escitalopram. And on their primary measure, they actually found a trend at every time point for psilocybin to perform better, to see lower reductions. That failed to meet statistical significance. There may be a power issue. It is notable you actually see decreases in the escitalopram long before you would expect it. You don't expect to see those improvements for a few weeks, right? SSRIs take a while to kick in. So even the reductions you see in that group, I would say is a decent shot is due to the preparation for the psilocybin sessions. Nonetheless, on other measures, including one interesting one, a well-being measure, showed statistically significant and large increase, and they found that on a number of other measures. So fell short on the primary measure, but that's in comparison to something that is approved, known to be effective for the treatment of depression. So I think it's promising, and more work needs to be done. Moving into substance use disorders now, I asked earlier, okay, so you're not going to get hooked on psilocybin. Why in the world would we expect it to treat addiction? And that's quite another thing. Well, the older work with LSD, again, same drug class, same primary mechanism. This was, as I said, one of the most prominent clinical interventions with LSD in the older work. A bunch of that work was looking at the treatment of alcoholism. However, only a subset of those studies were randomized. So there were only 6 randomized studies. They randomized people to either LSD or some other comparison condition. And previous reviews had sort of summarized this as a mixed literature. Some studies met statistical significance, found an effect, some didn't. The meta-analysis brought some light to this. I'm showing you odds ratio here. The individual studies have the horizontal lines on them. The big diamond at the bottom represents the aggregate data, the aggregate effect size. So what this odds ratio means is anything to the right of the central line at 1 suggests a odds ratio favoring the LSD group, and anything on the left favors the control conditions. As you can see, on average, everything was on the right. Sometimes those 95% confidence intervals overlapped with 1, which makes sense because some of them found a trend that wasn't statistically significant. Nonetheless, it was statistically significant on average, as indicated by the diamond at the bottom. But more importantly, is that effect size. the odds ratio of about 2. What does that mean? That means patients were essentially, their likelihood of being improved at the first follow-up, the timing of which varied across studies, but that was doubled. And so that's a big effect that I'd argue we'd probably be in a better place now had we kept pursuing this research and it had been dropped off and not dropped off for political reasons. Because yeah, that's rivals a lot of the best treatments we have today. There was one study published with LSD in the treatment of heroin addiction. There were some limitations. The groups were treated a little bit differently. There was a short inpatient stay for the LSD group. Nonetheless, a lot of strengths, biological verification, which was rare in 1973, and long-term follow-up. They found at 12 months substantially increased abstinence in these, and these were inner city Baltimore heroin users, the same types of folks that we see in Baltimore today. I mean, there's extreme poverty, and especially with that backdrop, I think this is really promising. We're going to be moving soon into, we have a study already approved by the FDA, haven't started it, but using psilocybin to treat opioid addiction. But I'll tell you about what some of the work we've already accomplished with using this to treat tobacco addiction or tobacco use disorder. And kind of there were those few early studies combined with a bunch of anecdotes of people, claiming that they quit whatever, any number of drugs because of a psychedelic experience. And I've done some survey research and found, cases that fit that model. It seemed to be there was some sort of anti-addiction efficacy that may have cross-drug class applicability, which speaks to something potentially very special. So I thought, why not try smoking? I had done work going back, beginning of my grad school work with smoking. It's very quantifiable as an addiction. Everyone knows basically how much they smoke, unlike the pouring of the scotch. You know whether you buy your pack once every day, once every 2 days, et cetera. So moving into that, it's a good model system of addiction. I'll say here, hopefully you all get the point. By this point in the talk, I'm not encouraging anyone to use on their own. There are risks. So don't do this just because I'm describing the research. But it's also good when people, we want the media to, report on our science, and we appreciate that. I will make the point, you don't always get the chance to verify. Even typically the writers of the story, it's usually the editor that selects the photos and the titles. So definitely, I'm not telling you to use mushrooms, but I definitely want to emphasize this. Don't do this many mushrooms. That's crazy. That really is. I mean, it really is. But there are risks to all of it. But it's all dose related too. Demographics here, the important things are they'd been smoking on average 30 years and smoked almost a pack a day. These were not lightweights. Multiple unsuccessful quit attempts across the lifetime. It was a 15-week protocol in which there were weekly meetings during that time. Most of them were cognitive behavioral therapy based meetings where we prepared them to quit smoking. Then we reinforced that content afterwards. Things very standard for quit smoking programs. So, keeping a smoking diary before you quit, assign a target quit date, but be more mindful about your cigarettes that you smoke, about the antecedents and consequences of smoking, et cetera. Things to remind you about you have this upcoming quit attempt. Training them for the abstinence violation effect. If you slip after you quit, don't dwell in guilt. We know that actually makes you more likely to fully relapse. Treat it as a learning experience. This type of thing. That's the CBT. 3 psilocybin sessions over an 8-week period. The first psilocybin session was concurrent. It was at a moderate dose, concurrent with their target quit date. So it's a big date for people. They're going to quit smoking. They're going to have this big psilocybin session. This is one of the 2 biological metrics of abstinence. We did both breath carbon monoxide and urine cotinine, both byproducts of smoking. This was before the first psilocybin session. These are meeting carbon monoxide levels. This is after. You don't have to be a stats whiz to see there's a pre-post difference here. I'll show you the data. And another way, point prevalence, this is at that verified by biological verification and self-report at these points in time, how many people were abstinent. 80%, 12 out of the 15 at 6 months. And then on average at 2.5 years or 30 months, 60%. So those are very high numbers. This is an open label pilot, so we can't really judge the efficacy, absolutely, but it's promising, certainly. Those are very high success rates. And we found here, again, like with the cancer work I showed you, that the degree of mystical type experience as measured on the session day seemed to be related to long-term success in quitting smoking. We did a qualitative analysis of this, and at 2.5 years on average after the quit date, and just asked people, did you quit? And if so, do you think psilocybin helped you? And if so, how? People emphasized, they said it did. They emphasized that it left them with a persisting sense of interconnectedness, all curiosity that helped them to quit. They said it reduced their smoking withdrawal symptoms compared to previous quit attempts. We have some data suggesting it may be more the affective rather than the somatic withdrawal symptoms that are most especially improved. Other positive changes, people reported altruism, appreciation for aesthetics, and they said this kind of just overall helped them. This was kind of a whole package that kind of improved their life and helped them to quit smoking. And they said they were insights into their own smoking, their self-identity as a smoker or as a non-smoker, and their own idiosyncratic reasons for smoking. I mean, some of them you may, I think as a trained behaviorist, they might be, ad hoc sort of explanations. Nonetheless, I mean, people really touch base with this narrative in their life, this story about them having been a smoker and then this transition into a non-smoker that seemed to be really highlighted by this intervention. And these are some of the things people would say. Primarily, I would say it made me understand my identity as this construct. I've learned to be more grateful, which is probably the biggest thing. I was given all these lessons that in that session telling me, here's what you need to do so you don't get so depressed. Don't need to smoke a cigarette necessarily. Seeing that which happened during the psilocybin experiences and being reminded of and understanding life as an unspeakably marvelous adventure of existence. It makes me think of that first talk, like those, you can hear those love letters, perhaps. I'm more accepting of myself. So an interesting note about all of this is there's not a lot of talk about smoking. I mean, this really, I warn people about this, but they come in and I tell them this isn't about more than smoking. And so often people months later will come back and they'll say, this was so much more than about smoking. And it just seemed like it's hard to emphasize this enough. Like you can't go into this and say it's only about my smoking. I think of a woman in the smoking study who had suffered severe trauma from 40 years ago. And boy, that you go into a high-dose psilocybin session and stuff like that, it comes up, and there is no telling the psyche, no, this experience is supposed to be about reflections of your smoking. So this is a very, very deep psychological process. So now we're in the midst of this 100-person randomized comparative efficacy trial. Comparing, it's not blinded. My next step, I really wanted to treat it like a novel psychotherapy. There's some difficulty with blinding psilocybin. For me, the next step, I thought comparing it in a blinded study to a known comparator is the next step that's going to make an advancement in really convincing me that we're onto something here. So, 50 people in psilocybin, 50 people randomized to nicotine patch. It's the same cognitive behavioral therapy that we used. We shortened it a little bit, largely the same. We went down to one psilocybin session. I think still multiple are ideal therapeutically, but this is more for experimental reasons. We were doing some fMRI before and after to look at biological correlates, and multiple sessions would kind of add noise to the equation. These are not official results. This is where we're at right now, but it's an open label study, so I can tell you where we're at this point. But the real answers are going to come at the end of the study, but the snapshot of where we're at right now is based on this number of people, 61 people, getting about 16 cigarettes a day on average, been smoking on average over 25 years. Again, not lightweights. In terms of point prevalence, where people are at, biologically confirmed with both methods. For the 31 people in the psilocybin group that have gotten to their 1-year follow-up, 59% are biologically verified as abstinent. And that compares to 28% for nicotine patch, which, by the way, is good. That's good for nicotine patch compared at the upper end literature value. So I'm very proud of that, especially in the context of an open label study where we're really trying to keep people to quit. Nonetheless, at this point in time, still being dwarfed by psilocybin, could change for sure. But right now, it's a promising snapshot. Thanks to those data, we were able to land this grant recently. to our knowledge, the first time the federal government since the late 60s has funded a therapeutic studies with one of these classic psychedelics like psilocybin or LSD. So there's actually a lot of excitement now at NIH. They invited me and a number of colleagues to speak at an NIH-wide workshop on exploring the therapeutics. I mean, there are people from the Mental Health Institute, from the Drug Abuse Institute. The directors of both those institutes were represented and actually enthusiastic. So we're in a real time now where things are changing in this area. I'll mention my good colleague, Mike Bogenschutz, has a very similar line of research with alcohol use disorder as what I've shown you with tobacco. He published this 10-person open label study with showing that 2 psilocybin sessions were followed by a large reductions in drinking days and heavy drinking days, self-reported. He used motivational enhancement therapy rather than CBT as the therapeutic backdrop. His doses were similar, he used a moderate and a high dose. So similar line of trajectory. The big question here is like, what's going on? I mean, you should be suspicious of snake oil. Like, okay, this works for everything you throw at it. I don't think it will. I think we're going to see boundary conditions. But the big question is like, what's going on across these different disorders? How could it help potentially with depression and with different forms of addiction, which is amazing enough, and with depression, anxiety, whether it's in cancer or outside of cancer. And Michael Pollan wrote a really interesting book about this modern research with psychedelics called How to Change Your Mind. And he quoted with me based on one of the conversations we had. It sounds like a horrible scientific name, but it's the dope slap effect now. This is after, I don't know, just a long conversation it's like, how does it really work, Matt? It's just like people are slapped out of their stories. And this is how I see it. And in fact, I've come to think of a lot of these disorders, whether it's affective disorders like depression, as forms of addiction. People are stuck in their story. God's punishing me, I have cancer. This is my fate in life. That's the story. Or major depressive, people hate me, I'm a failure, I'm never gonna make it. The story. We all tell ourselves to some degree, overexpressing depression. Smoking, alcohol, I'm a smoker. I've tried a million times, it's not gonna work. I started too young, it's in my brain, I'm just wired like this. These stories. People can get really blasted out of those stories after a good psychedelic session. And we're seeing in rat research, not my group, but others, this unfolding neuroplasticity. If I'm thinking of the work of David Olson, Brian Roth, Alex Kwan, there's a number of researchers at top universities that are seeing neuroplastic changes, even in rats exposed to these drugs, which might be consistent with this type of narrative. So again, we're gonna have to do a lot of work to fill in, to add more meat to the scientific bones. But I think it's something like this, and the real questions here are about that transdiagnostic efficacy. What's the commonalities when someone is treated for depression or tobacco use disorder? And I think that's what this slide is all about. So I'll skip past that. So we're doing a bunch of work now, continuing the smoking cessation work. We're trying to help the depression within early stage Alzheimer's disease. That study's running. We have a study with comorbid depression and alcohol use disorder now, a study with anorexia, and then a number of upcoming studies, LSD to treat chronic pain, opioid addiction, PTSD. Other than the LSD study, these are all psilocybin studies. PTSD, I'm going to be PI on the opioid addiction, PTSD work, LSD work. But a number of studies that our center is going to be doing over the next few years. And I guess kind of one wrapping up here, I don't have time to summarize the whole thing, but I'd encourage people, if you're interested in this area, I'd refer you to this viewpoint piece that I wrote a little while back, Consciousness, Religion, and Gurus, Pitfalls of Psychedelic Medicine. And here, this is where this is where I took like 17 years of pent up, these are the icebergs I see in this field. And in fact, it was important it was a single author publication because it's somewhat of a hopeful, a constructive critique on even very, very close colleagues doing this work. One thing I'll emphasize here, these are powerful treatments. It's not uncommon for people to say this is one of the most, if not the most meaningful experience of their life. That's really difficult to handle clinically. I think, unfortunately, there is a risk in this area of thinking that these experiences are so big, they transcend what we normally do clinically and scientifically, and new rules need to be applied. And that can be a very, very dangerous thinking. I call that psychedelic exceptionalism. I think it's the exact opposite. Because of the magnitude of what we can do with these sessions, it is absolutely critical to cling to all of that, all of those professional boundaries that we learn in medicine and clinical psychology and in social work and nursing, et cetera. The wisdom of those boring old traditions, the role of physical touch in these sessions, the implementation of metaphysical systems that we can't really speak to scientifically. One of the practical things is it's really common for the researchers to set up these rooms with Buddhas and other religious. What are we saying to the Muslim or the, Dawkins style hard atheist that wants to participate? And I've seen people of all these varieties profoundly help. What about a lot of my extended family members, more fundamentalist Christians? Are we telling them this isn't for them? Hey, I say bring your own bring your own meaningful items. If you want to bring the Buddha for your session room, absolutely. If you want to bring, Jesus, if you want to bring the flying spaghetti monster, you might have been wondering what that was about. You're free to bring that too, but we need to, and our job isn't to tell people, no, that wasn't Jesus speaking to you during your session, or a plant spirit, or who knows what, okay? Because we don't know that to be the case either. But we're not there to drive the bus in terms of the metaphysical interpretation of these sessions. We're there to provide that support for them to help meaning and keep our clinical radar up for any flags. It's one thing to think Jesus talked to you during your session. It's one thing to think now your neighbor's dog, Jesus is talking to your neighbor's dog to you, or you're hearing him through the radio. You get it. So anyway, I think we're going to get into some interesting territory here in terms of got to watch out for those clinicians that are coming off more like gurus, and they have a practice that looks more like a spiritual retreat. And so there's going to be problems there, but I think we need to go into this area and tackle these issues up front, because the healing can be so incredibly powerful. And I think that's my slide. I feel like that's my last slide and statement. So thank you to a large number of colleagues, and you can find out more about our group at our website.
Dr. Johnson gave this presentation at last April's Addiction Medicine Conference in Asheville, North Carolina. The website he mentioned for more information is hopkinspsychedelic.org. You can also find his contact information and presentation slides at addiction-medicine.org. That's also where you can find more information on the Addiction Medicine Conference 2023, which will take place March 24th and 25th. The conference, along with Addiction Medicine Essentials in the fall, is a joint partnership with the North Carolina Society of Addiction Medicine, with funding from the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, the North Carolina Division of Public Health, and the Substance Abuse Mental Health Services Administration. If you like this podcast, please rate it, or better yet, share it with your networks. Thank you for listening. Have a great day.